Yeah, all good.
Okay, excellent. So we'd like to start by acknowledging the traditional owners and the custodianship of the lands on which we meet today. And we pay our respects to their ancestors and their descendants who will continue cultural and spiritual connections to country. And we recognise their valuable contributions to Australian and global society. So today I'll talk about a project called CRISPR that I've been involved in since the beginning of the pandemic. And it stands for COVID-19 Real-Time Information System for Preparedness and Epidemic Response. And I'll also start by saying that I'm not an AI expert. So my background is in medicine, infectious diseases, public health and epidemiology. But I do have a big interest in the use of digital tools in epidemiology, including things like data collection, data visualization, interaction with real-time data, and making data more usable to people. So that's where I've started working with data scientists, digital health people, etc. Oops. So the aim of this project, which I've been leading, is to provide a national real-time information and visualization system for COVID-19. And data visualization and mapping is really important for improving information sharing and communication for an outbreak like COVID-19. And interactive tools, which we'll talk about, also allow us to interrogate data in a way that static information will not allow us to do. So I'll also show some examples on that. And the three key things in epidemiology are time, place, and person. So to be able to interrogate data and ask specific questions about when and where and who all together, not just one by one, is quite important. And interactive mapping of exposure sites. So, we all know about these sites that are advertised on the media and in health department websites telling us where infected people have been and what we need to do if we've been there. And also to develop an automatic alert system of some of these types of information. So our project has a special focus on improving public facing information. We know that there are dashboards and information that sort of sit within health departments and other government agencies that are not accessible to the general public. But it is really important for people like GPs and other primary care providers and the general public to have this sort of information. So in my previous life, I was a GP for about 15 years, and so many of my colleagues have made comments about, just not being able to easily access information. And often the first thing they know about new exposure sites or cases is from their patients, because, they're just too busy to look up different sources of information during the working day. So a few different rationales behind our project. Sharing real-time surveillance data is actually a core component of Australia's health sector emergency response plan for COVID-19. So it's really important for everyone to have accurate and timely information from official sources, ideally. So this includes not just the decision makers, but public health responders, clinicians, general public. And we have a big focus on mapping in this project because of the spatial nature of these sorts of outbreaks. So mapping helps us to identify exposure sites, clusters, hotspots, and generally speaking, they're much easier to interpret than tabular data. And there's really a current gap, and I wrote this kind of close to the beginning of the pandemic, and there still is a current gap in the availability of public-facing, national, easily accessible real-time information from an official source. So there are various media groups and independent groups that have produced various dashboards and websites, but all our official information are limited in some way or other. So it's not that we don't have information. So this is the Australian Department of Health that gives national level information. And they've been producing these daily static PDF infographics since close to the beginning of the pandemic. So every day we get a new one of these, and this one is from the 11th of October. So it does give a summary of various things, And we've got this huge repository of daily infographics now for each day. But these are all completely static, so you can't interact with them, and everything is aggregated. So when we talk about time, place, and person, we can't ask questions like, how many new cases in each state in the past 24 hours? We can roughly see, how many cases there have been in the last 24 hours. We can see the total number of cases for each state for the whole entire outbreak, but we can't actually answer this question. Or how many locally acquired cases have there been in Victoria in the past week? We can't answer that based on what's been shown here. How many tests have been conducted in Queensland in the past week, for example? Again, we can't tell that from here. So even though it looks like there's a lot of information here, it's not really fit for purpose for a lot of potential end users for this sort of information. So each individual state also has their own website. They're all structured differently. They show information differently. So in Victoria, they do have a mapping tool, but a lot of this information here, like total COVID cases in the whole entire, I think this is a postcode for the whole entire outbreak, is not really very useful, and I can't stratify this over time. And I do have a graph of cases over time, but then this is not stratified over space. So it's still quite limited. This is Queensland. So we have a page like this showing cases, etc. And very sadly, the maps on Queensland Health have not been updated since December last year. They are completely static. So this is just an example of some of the maps there. So really, 8th of December 2020. Then New South Wales Health probably provides the best sources of publicly available data. They have quite a nice mapping tool here, and these red circles here show the locations of exposure sites, and this is an interactive tool. However, it's just for New South Wales, and so people do travel between states normally, and it is difficult just to sort of get a big picture of what's happening across Australia. So, given all of those limitations, what our project really aims to address is these list of things. So, like I said, data visualization by time and place and source of infection. We have been wanting to stratify also by age, gender, and other things, but access to data has been extremely challenging, which I'll talk about as well. And like I said, to be able to interrogate data and answer specific questions, an automatic alert system that tells you what's happening in your own areas of interest, and to be able to easily access these exposure sites at a national level. So I'll show you that later. And also to apply differential privacy mechanisms to protect data confidentiality, to build a platform that we can use for other outbreaks and other public health emergencies, and to provide access to national level data sets that we've collated and cleaned and worked on. So this is what the CRISPR system looks like as an overview. So firstly, there are data, we have different data sources, which I'll talk about later. At the moment, it's all publicly available data, but soon, hopefully, we'll also have confidential data, meaning data that are not publicly available that we may need to protect in some way. Then we have data feeds, mostly through automatic APIs coming into what we call our data engine. And so in the data engine, the data are cleaned, integrated, transformed, harmonized, analyzed, etc. And currently it's hosted on the ANU National Computational Infrastructure. So I was based at ANU for the last 5 years before I moved to UQ in January. So this project started while I was at ANU, and that's why it's hosted there. So publicly available data come into what we call the public database, and confidential data go into firstly a private database, and then we apply differential privacy data transformation, which I'll talk about later as well, goes into a public database, and then that then talks to our end user dashboards, mapping tools, mobile web apps, and then also an automatic alert system where users can define things that they're interested in, such as information about a particular local government area or postcode, and they can get email alerts if things happen in those areas. So just very, broad overview of how the system has been set up. So we do have a website of all the different tools that have been developed through this project. And the most popular tool so far has been the web app for exposure sites. There's also a link to all the automated alerts, various other dashboards, and also data engine. So I'll talk about most of those. So firstly, a national summaries dashboard. So this is just a screenshot, but you can go in and play with it later. So we can actually interrogate information here based on time and place and person. So this one is by state. You can select whichever states you want, a summary of the daily updates for each state, but sometimes it will be 0 if it hasn't been updated for the particular state for that day. So you can click onto any of these boxes and interact with the data, and also stratify by different types of moving averages. So the top row are cases, second row are deaths, and the third row are related to testing. So these are just the first column are just numbers, then moving averages, then cumulative numbers. So just different ways of showing the data for different users. So as an example, if we just select Victoria, this is what it looks like. These are all the same bits of information for Victoria. And this is just starting in 2021 January. You can see, the progression of the recent outbreak. And like I say, you could go, deeper into each of those graphs and look much more closely at the different sorts of data, and also determine the date range that you're interested in. When we first built that dashboard, the public health units in New South Wales asked if we could do something similar for all the different public health units in their state, because they couldn't easily see data from the other public health units. And of course, people do move between public health units. So this is similar to the previous one, but you can select the different public health units and look at cases, moving averages, cumulative cases, etc. So that's just a very brief summary of the national and New South Wales dashboards. Then we have various interactive mapping tools, which actually do allow you to look at everything by time, place, and source. And at the moment, we've just managed to include Queensland data in here, because Queensland has just started making the data available at postcode level. So we can filter again by date, by source, and as you zoom in out of the map, the epidemic curve is what we call this in epidemiology, a number of cases over time. This interacts with the map, so this will change depending on what's in the map window, and various other bits of information such as aged care facilities or exposure sites can be overlaid on this map as well. So that's the interactive mapping tool, which is quite detailed and complicated, and probably too much for the general public to use. You can also go back into historic cases and overlay all sorts of different information and gauges. When you click on different bits of information like aged care, for example, you can have a look and see what that place is, and details about it, contact information, etc. And like I said, and the epidemic curve is dynamic, so as you can see, this looks quite different to the previous screens because we've zoomed into a different area. So this sort of tool could potentially be useful, say if you're a GP and your clinic is here and your patients mostly come from around there, and these are the nursing homes that you look after. You can see what sort of activity there has been in the recent 7 days or 14 days, and filter by various time periods. Also by the locally acquired cases, which gives you an indication of what's happening with community transmission. So all the overseas acquired cases are in hotel quarantine and generally don't pose a risk to the community. I'll skip over this one because the mobile app is the one that's mostly being used now instead of the mapping tool for these contact tracing alert locations. So this is an app that works on your desktop, but also is mobile friendly. So we've called it a web app. We weren't able to put it onto the App Store because apparently only governments are now able to put COVID-related apps onto the app stores. But once people have saved this on their home screen, it pretty much works like a web app. So essentially, you can search for any place. So if you search for, Brisbane, for example, this will come up. And if you zoom in high enough, you get little pop-ups of the names of those places. And if you click on any of these red dots, a little window like this will pop up showing you the times and dates that an infected person had been there. And if you have been there, there are some instructions about what you need to do. And this is a national level app, so you can see exposure sites for the whole country. And this is particularly useful for people who've traveled recently or people who live near border areas so that they don't have to go and check long lists of exposure sites on multiple health department websites. And contact tracers from health departments have also contacted us to, specifically ask for different functions because they found it's really useful for contact tracing of people who've been recently interstate. I haven't zoomed into anything that shows transport icons, but if you zoom right in, you will see some icons that look like these, like flights and trains and buses that have been alerted as exposure sites as well. So yeah, we've had a lot of usage of this particular web app. So the automatic alert system, the idea is that, say you're a member of the general public and you want to know what's happening around where you live or where you work, and you don't have time to keep checking these sort of information sites all day long. Or if you're a GP and you want to know what's happening around the suburbs where your patients live, but again, you don't have time to keep checking things all day long, you can actually go in here and define the information of interest to you, such as postcodes or local government areas, and receive information about cases or about exposure sites. So it's a passive engagement of set and leave. You can just go and explore, meaning that, you can just generate a report straight away and have a look at it, or you can register and have it sent to you on a regular basis through emails. So it looks a little bit like this. You can select, in different sorts of locations, different types of information, and the level of information is different between different states because each state provides different types of information to the public. So it's all quite complicated to try and put all these different bits of data into a consistent format for the whole country. So we also have a data engine, and we've collected a lot of data since the beginning of the pandemic, including a national level database on all the exposure sites and the times and the types of places that they are. And we've decided to make all of this publicly available. So like I said, I'm not an IT person, but you can go into any of these tiles here and get access to data in different formats, or if it's not in the format that you require, we can potentially provide it to you in, say, CSV format, for example. So there's a link to that on the CRISPR website as well. So where do we get all these data from? That's been the biggest challenge of this project. Building the tools, of course, took some work, but once the tools are built and they're working, they're nice and stable and they're fine. But in terms of data sources, they have been a moving feast. So that's been our biggest challenge and a biggest use of our resources. So one type of data source are publicly available data sets that are available for some states and territories, but not all. New South Wales started first, so they have a COVID data program. And in there are all sorts of different data, including APIs for cases, testing, clinics, and exposure sites. So we write APIs to these sites and directly download the data to our tools. every couple of hours. So usually as soon as data are updated on New South Wales website, it will get integrated into all our different dashboards automatically. The other thing is scraping data from websites, which is a lot more challenging. Excuse me. So for those of us based in Queensland, this is probably a familiar table. So they have a list of exposure sites, and every state has something similar. So this list can become very long very quickly, and it's a real challenge for people to, find what information they need. So we turn all of this into our mapping tool, but this needs to be scraped. It's not in any kind of a CSV file. Excuse me. So, don't worry, I'm not sick. I've just got a tickle in my throat. Whoops. So, like I said, the biggest challenge has been access to official data, especially real-time data. So we've been getting it from state and health departments, and also the National Notifiable Disease Surveillance System, or trying to. So apart from what we already have, we could potentially make our information much more detailed if we had line list level data on age, sex, other demographics, ethnicity, etc. And that has taken more than a year now, and we have not been able to access any kind of confidential data from health departments. So we're working with, various groups at a higher level to try and resolve this issue. And this issue is not unique to our project. It's a project across, all issue across all, nearly all projects related to COVID in Australia. Being able to access data in a usable format is also a challenge. So for example, CSV files. So we've had to scrape a lot of information, and the data format is different between states and territories, and also changes over time, which means that our scrapers break and we have to, renew it. So we've written scripts to automatically detect errors in the scraping. And also we have people in our team just checking the exposure sites tool, especially a couple of times a day, just to make sure, data are coming through properly. So it's very time consuming. But if the data were available as APIs in CSV files and it was stable, then it really wouldn't require any work on a day-to-day basis on our part. So we've had to access some data from unofficial sources, which is not ideal, but it does save us a lot of work. And we've only limited this to a couple of independent websites, but they in turn also access data from media and other sources. And one of the other challenges, which I think will help with accessing data in the future, is to be able to share data, or at least share the patterns in the data, while protecting privacy and confidentiality. Which takes me to this new point about differential privacy. So we've been working with the ANU Software Innovations Institute on this, and they have expertise in this differential privacy space. And it's been used in quite a few big projects, such as the latest release of the US Census. And the idea is to introduce some statistical noise into the data, where the noise is significant enough to protect the privacy of any specific individual, but small enough that it will not impact the accuracy of the answers extracted by analysts and researchers. So in other words, overall patterns of the data, which is what epidemiologists generally interested in, are the same, but the chances of you being able to identify an individual becomes extremely low. So we thought that this would be a really useful tool for public health surveillance data. And we have a paper in press at the moment in Patterns, where we have applied the differential privacy mechanisms on a synthetic data set that we generated. And we had an example use case of an adversary who has all the tools that she could possibly need, and she has all the information about people's COVID infection status in the community, except for one person. And so this one person, if they were or were not, and if you were interested in whether this one person was or was not infected with COVID, and you wanted to find that information, how can we protect this person's data and not allow the adversary to actually identify whether this person's been infected? So to cut a long story short, if this last person did have COVID, our data will look a bit like the blue dots. And if they didn't, it will look a bit like the orange dots. So the patterns are the same. And if we plotted the age distribution of the actual cases, the real data looks like the blue, and the perturbed counts, which means the data that have been messed around by differential privacy, look like the the orange counts. So the patterns are the same, but it means that we are protecting that last person's privacy. So I'm not an expert in this. I'm just putting this out here for people to consider as one potential way of making it a little bit more comfortable for authorities to share data. So next steps, we are in the process of evaluating the usability and usefulness of these tools. We've had quite generally very good feedback, including from government departments and authorities like contact tracers and people who, during an outbreak want to make decisions about whether they want to deploy their staff out to certain areas to do non-urgent jobs, like pruning trees, for example. So if it's a high risk area, we can wait a few weeks to prune our trees. And so these sorts of tools have been useful for them to make these decisions. And, they do have that information elsewhere, but it's just much more accessible. We're also thinking about improving functionality and usability of tools, including on-device analytics of different sorts, integrating these CRISPR tools with our other projects. So for those of you familiar with the SMART project, we're thinking about adding a spatial and temporal component to risk-benefit analysis of COVID vaccines. So we've got a preprint out looking at the risk-benefit analysis for the AstraZeneca vaccine using Bayesian networks, but there's no spatial or temporal component to this model at the moment. But we have spatial and temporal data from, say, postcodes in Queensland. We could potentially model that risk versus benefit at different spatial levels. And then it'd be really good to discuss some research ideas using the extensive databases that we've collected in our data engine. And some of the people in this call, I think, have already started to think about some of those things. So, I'd be really interested to talk about this with anyone who's interested, with postdocs in our team, for example. So there's been a large number of people involved with this project. A number of people on my team here at UQ, but also many colleagues at ANU, building the mapping tools and dashboards, Software Innovation Institute, and the supercomputers at the National Computational Infrastructure. And the project is funded by PRIZE, which is an NHMRC Centre for Research Excellence. So yeah, thank you to everyone who's been involved in this work over the last 18 months or so. So that's all from me today, and thanks everyone for your attention. Be happy to take any questions or discuss any ideas.
Great talk, Colleen. So we have 10 minutes to ask questions.
Oh, in Victoria now, I think we've given up sort of keeping close track, contact tracing and so on. But when I sort of had some mapping ideas about how you could visually explain to the public each day, what the risk or increased risk, the level of exposure was, because I thought they would publish a number of cases, but they wouldn't even then follow up with, the number of those that were fully in quarantine or partially in quarantine and how well they were linked and so on. So I just thought without exposing privacy, and privacy seems to be something that really sort of hamstrings the important public, value of this information situation like this. People get really, hooked up on it in a way that I don't think they need to. But I would love to have seen a sort of a graphical thing which said, well, look, today, look, it's grown like this, linked in graphically, but with, and then maybe there's a case over here, there's another case over here, but this case looks bigger because the person's had more contacts and they were out in the community more, and this one's smaller. I just thought that would be, so I mean, I love the stuff that you're doing. I think it's really, really important. You need to access these things in the right way. And it's amazing that, somebody hasn't tied it together in terms of, just the record keeping, just a few basic standards about how you store this data so that you don't have to put so much effort into just sort of collating in a reliable way. But I'd love to have seen that graph. I tried to talk to a friend of mine who talks to the Chief Health Officer down here, and they had some graphing tools internally within the Victorian one, but they haven't made them public.
Yeah, thanks, Robert. Those are really great points. And we've certainly talked to people within health departments, and, some of them are using these tools. And so we can show the exposure sites through the web app, which you can also use on your desktop, and, click on each dot and show people where the exposure sites have been. You can also filter those by date as well. So you can look for, exposure sites that have been reported just in the last day or last 3 days or whatever you're, interested in. But those are the sites that people have been to. It doesn't mean that transmission has actually happened through that site. Now, that level of information we don't have access to publicly. But we can map out by postcode the number of cases that have been reported at each postcode. There are some limitations to that data because it's based on residential postcodes, and people might not have acquired their infection around it where they live. They could have acquired it from work or, somewhere else, public transport, etc. But it is still useful to be able to visualize that. And, I certainly know clinicians, for example, who would show that to their patients to try and convince them to go and get tested or to go and get vaccinated. Particularly people who feel that they haven't been at risk, and you can show them, look, like how many cases there have been in our area in the last week, and look at these sites, they're all over the place around where you live. So even though you just have a bit of runny nose, you really need to go and get tested. So people have been using it in those ways, but I agree that the official, media releases and public information sharing has not really made the most of visual spatial kind of tools. So yeah, it is a challenge. Yeah, and to show these things at a national level, we need to bring all the data, together into a national database, which we have done, but we haven't made the most of the data in terms of research, and we're just starting to think about that now.
Other questions?
So I'd be, really interested to hear if anyone thinks there are different functions that might make things more useful. So for the web app, for example, we've just added another layer showing the Commonwealth declared hotspot LGAs, local government areas that have been declared as hotspots. But even that is different between states. Different states declare their own hotspots. But we started doing that because it became apparent that some of the public were quite confused about the difference between exposure sites and hotspots, because they think that they're in a hotspot. They look at our tool and there are no dots there. So even that is still unclear to people this far into the pandemic. So we've mapped out hotspots as polygons and exposure sites sitting on top of them as places that infectious people have been to. There are some limitations to the exposure sites data for New South Wales because they've stopped reporting them. As there were just too many, and they stopped reporting them a few weeks ago now.
All right. If there is no other question, all right. Thanks very much, Colleen, and the participants for joining us, and looking forward to seeing you in our next seminars.
Thanks,
you.
Colleen. Thank you.
Thanks, Amit, and thanks, everybody. Thanks for the invitation.
Yeah, thank you.